Well, welcome. Thank you very much, everyone, for joining us. My name is Steve Ansell. I'm at Mayo Clinic, and I'm joined with three other experts. I'm going to have each of them introduce themselves just briefly, and then we'll get into a conversation around BTK inhibitors. So, Sheba, I'm going to have you start, if you'll go ahead.
Hi, I'm Sheba Thomas, and I'm at the MD Anderson Cancer Center in Houston, Texas.
Great. Thank you. Christian.
Hi, my name is Christian Busker. I'm located in southern Germany, hematologist, oncologist in Ulm University Hospital.
Welcome. And then Monique.
My name is Monique Minema. I work as a hematologist at the University Medical Center in Utrecht, the Netherlands, and I'm specialized in plasma cell dyscrasias, amongst Wallström is also one.
Well, thank you very much to each of you for joining us. And the discussion today is around the Bruton tyrosine kinase, BTK inhibitors. And so we really just wanted to have a comprehensive discussion that really addresses everything from exactly what they are and how they work, through who needs them, how do you use them, what are the side effects, what are the benefits, what do you do if they don't work, and potentially what do patients really prefer as their primary therapies for Waldenström's. So maybe as we get started, Sheba, you want to just give us a little bit of insights, and then others will chime in too, as to when you think about a BTK inhibitor, how exactly does it work? What exactly is it doing?
So one of you may have a better, more comprehensive answer than me. I think of it as blocking or inhibiting the Bruton tyrosine kinase, which is in the BCL receptor pathway. So we're trying to block some of the pathways that allow these Waldenström cells to grow and divide.
Excellent, thanks. And so, Christian, anything you wanted to add that we should know about the activity of this pathway?
No, I think you said it quite in a great and understandable way. So it's really a very important intrinsic growth signal, which we find in normal B cells, we have to say, but also in Waldenström cells. And I think the charm is that Waldenström cells are more addicted to this growth signal, which is triggered by BTK. So, and actually we are using this therapeutic window, this addiction of Waldenström cells, to block this signaling protein in that sense, as you explained before. I think it's also important to note that in contrast to chemotherapy, we are not dealing with a DNA damaging agent, but we are really interfering at the protein level and interfering with these signaling cascades, which are so important for Waldenström. And in particular, the point that we are not using DNA damaging agents, I think, is a clear-cut advantage compared to conventional chemotherapy.
Well, thank you. And Monique, anything you would like to add to that?
I think it's quite comprehensive, but it's believed that in Waldenström, patients having this MID88 mutation that is present in most patients is because it's mutated. That's the reason why the Waldenström cells are more addicted to this BTK pathway than your normal B cells. So that's the window that Professor Busker talked about, and we do believe it's aligned with the mutation that's also so typical in Waldenström patients.
You know, I think all of those are excellent points and really help us understand. I think also, you know, as new BTK inhibitors have come along, you hear comments like more selective, and you hear comments about covalent versus non-covalent binding. And I think the important thing to know is that nothing is exactly perfect. So a BTK inhibitor, particularly the first generation ones, may actually block a few things more broadly than just the BTK pathways, and they may shut off some cytokines and may actually block some other pathways. So I think we've also learned that there's a spectrum, and sometimes that has an association with some of the side effects that we see. So I think, as you all said, key thing is it's a pathway that Waldenstrom cells are really very sensitive to, and when you inhibit that pathway, the cells really just then run into a lot of trouble and shut down. So I like the comment you made, Christian, about the it's not DNA damaging therapy, and quite frankly, we have other treatments which we commonly will use for Waldenstrom's that are in that category. So when we're thinking about BTK inhibitors and we're thinking about a newly diagnosed patient, where do you think BTK inhibitors fit in, and who should get them as a frontline therapy?
That's a good question. So in some way, it's a situation where we have different very good treatment options. So when we have a patient newly diagnosed, treatment naive, rituximab chemotherapy is still widely used, and I think the advantage of rituximab chemotherapy is it's a fixed duration treatment, and we have a long experience with this. And of course, yes, we have this DNA damaging effect, but when you think about an elderly patient in the 70s of his life, let's say, I think these DNA damaging events are not that crucial anymore, and we are not so much concerned about long-term, side effects. When you have a young Waldenstrom patient, and we have patients who are in the 30s, I would be more reluctant to give these young patients chemotherapy, and I would prefer, in these cases, indeed, a not DNA damaging agent such as a BTK inhibitor. So, of course, we have also data showing the efficacy depending on the MYD88 and CXCR4 mutations. And Monique already mentioned it. So when patients with Waldenstrom are carrying non-mutated MYD88, we know that ibrutinib as a single agent is not that effective. So these genetic landscape of a Waldenstrom patient can impact our treatment decisions. And we know that for these patients, probably our chemo or second generation BTK inhibitors or ibrutinib plus rituximab are the better choices than ibrutinib single agent. So I think, as I said, both treatment options are great, but age plays a role. Of course, the patient decision, the patient's social environment. What about compliance? And, the one is a non-fixed duration oral treatment. The other one is a IV, mostly IV fixed duration treatment. So there are many factors, but in total, we have more than one great treatment option for our patients in first line.
Well, thanks so much. Monica, how do you think about things? What do you typically like to do in frontline relative to BTK inhibitors?
Let's say it's true. It's different, also perhaps a bit per country, because in the Netherlands, the first choice is still rituximab chemotherapy, and the BTK inhibitors are only allowed to prescribe for very frail elderly patients. So in that sense, there is some regulation there, and it also has to do with compensation with the money it costs. Our chemo is less expensive than continuous BTK inhibitors, and our government has an opinion on that. So we are more restricted in that sense. But I also feel performing it that way, that I also feel very comfortable with it, because DRC, which is a standard first-line treatment in the Netherlands, is very well received. It's working in many patients nicely, and patients do like the start and stop aspect of it, and then again wait and see. And also with the BTK inhibitors, I must say they also work wonderfully, but they don't work indefinite. So there's one day they also have to stop because the disease becomes refractory to it, or patients do not tolerate it anymore. So it's not like a antihypertensive medication that you can use for 30 years on. We don't have the data for 30 years, but it's believed that in the end, most patients will have to stop with it. So I like the idea of sequencing in that sense. And for us in the Netherlands, still our chemo is first choice.
Thank you. And Sheba, what are you guys doing at MD Anderson?
Yeah, I think it's always a discussion with the patients. It depends on their gene mutation profile, but also what symptoms they are coming with, how quickly we need a response. And I think financial aspects do play a role, particularly in the United States, perhaps. And so it's also about what side effects patients are able to tolerate or are based on what, say, bendamustine rituximab, for example, would cause in that, especially in those first months while the treatment is going on, as well as long-term toxicity of bendamustine rituximab, for example, versus what side effects the ongoing use of a BTK inhibitor may have and how it may interact with other drugs that the patient may be taking on an ongoing basis, as well as, for example, interactions with antibiotics or other kind of more short-term medications that have drug interactions. So sort of collectively taking all of these into account and discussing that with the patient.
Thanks. And Christian, you made a comment earlier about we are fortunate to have highly effective therapies, and many of them for frontline treatment. So when you're considering a BTK inhibitor as a frontline treatment, what are your expectations? What do you kind of think is the likelihood of response, and what do you think is the durability of it?
Yeah, so I think what you would expect is that a patient shows a response very fast. So we would actually expect that a patient who starts on an BTK inhibitor shows a response within weeks. So let's say 4 to 8 weeks, we should see a movement in the IgM and also in constitutional symptoms. So it's a fast-acting drug. I think that's very important. It depends a little bit on the genotype. So we know that patients with a CXCR4 mutation need a little bit longer to respond, but we should expect this. So then, what we would also expect is, again, a little bit depending on the genotype, is a response rate around 90%. So I think there would be only a minority of patients which would not respond, and we would actually go back to our diagnosis more or less when we would see a complete failure in response. We know this a little bit from ibrutinib with the MYD88 wild-type patients. We discussed it at the beginning, but with zanubrutinib, we see a major response in over 60% of patients, even in the MYD88 wild-type constellation. So from the progression-free survival, we think it's as good as quite heavy chemo, so it can be comparable to the effects we see with our bendamustine. So where we have a progression-free survival or the time to next progression, let's put it this way in this context, over years, so 4, 5, 6 years, we would expect that these remissions last. There are always differences. Of course, we have patients who have shorter duration of remission, but most of the patients stay in remission over years. So this would be our expectations for these new drugs.
Right. And Monique, you touched a little on this, but, side effects generally well accepted and well tolerated, but what do you caution patients about potential, negative effects of treatment?
BTK inhibitors.
Yes.
Yes, so with the BTK inhibitors, it depends. I do have a preference, I must say. There was a phase 3 study that compared the two mostly used drugs at the moment. And so if patients are taking zanubrutinib, I warn them for infections and neutropenias. But else and of course, perhaps a little bit of bleeding, hypertension, cardiac disease, but it's much less seen than with ibrutinib. And also with ibrutinib, we do see a little bit more GI, gastrointestinal symptoms, some diarrhea, some joint pain. I had patients that I had to dose reduce because of that. So I try to explain this all to them, especially the infections, of course, remain a serious attention for us as treating physician, but also for the patients. I do like all my patients to be vaccinated. But that's a general story. But I must say, in the end, they do wonderful on this type of drug. So for me, it's also a little bit of a wonder that you only have to see them, for example, 4 times a year, because they are doing great and don't need all this additional support that you need to give, for example, with chemotherapy.
Thank you. Sheba, Monique touched a little bit on her selection of a BTK inhibitor. I mean, there's almost an abundance of riches right now where, ibrutinib, acalabrutinib, zanubrutinib, and then 2 or 3 more that are kind of in development. Do you have an ability to pick between them, or do you think there are different circumstances that really promote a different one at a different time?
I think, like Monique, I tend to favor zanubrutinib these days because of the lower atrial fibrillation risk, and I believe better GI toxicity. There is, as Monique mentioned, more neutropenia with zanubrutinib compared to ibrutinib, so that is a consideration. Acalabrutinib, we don't use as frequently, although having participated in the phase 2 study of acalabrutinib, it is very, I have patients who are still taking it this many years later and are doing very well on it. So certainly, while there is, again, atrial fibrillation, bleeding risk, I think overall fairly well tolerated.
Christian, any thoughts from you as to selection of one agent over another, or are you ready, zanubrutinib is your go-to drug?
Yeah, so we are in Germany, we get both reimbursed, so we can really pick. But I think it's a clear trend towards zanubrutinib. So we think it's more effective. So the data in the clinical trials are not academically significant, but I think it's like a general observation that zanu has also more power in reducing the tumor burn, getting deep remissions, acting in MYD88 wild-type patients. But the more important point was already raised. I think it's the side effects. And for us, when we choose between ibrutinib and zanubrutinib, we take zanu.
So what happens if you've picked zanubrutinib, you've treated it, and the patient's beginning to progress? Monique, maybe to ask you, are you done with BTK inhibitors, or are there still other BTK options that one should consider?
Well, I think there are options, but not for patients in the Netherlands. So I was wondering, actually, from all the other participants, if they have experience with pirtobrutinib in that sense, because there are some data that it can still work in ibrutinib or zanubrutinib refractory patients. But for my patients in the Netherlands, it stops there, and we have to move on to other types of drugs, like BCL2 inhibitors, for example.
So, Sheba, you've really been at the place that has pioneered pirtobrutinib, for example. So your thoughts on that as an effective agent if a different BTK inhibitor has failed?
Yeah, so there is data. Leah Palumbo presented it very nicely, showing that it can be efficacy of pirtobrutinib in patients who have previously had the other BTKIs. Unfortunately, in practice, I have found it difficult to obtain for patients. I have been successful with appeals, but it has required quite some effort to obtain it for patients as standard of care.
So maybe a last question. Again, as we think about all the options, and Christian, I'll come to you, seeing you raised it right in the beginning about how we have a variety of very effective therapies as frontline treatment. What do you believe patients would prefer when you take frontline treatment and get to a point where the patient needs to get treated? What do you think?
I think Monique has a nice study on this, so she.
Well, but let Monique have the last word, so we'll get back to her in a second.
Yeah, but it's from my daily experience, it's really different between patients. So some patients really want to have a fixed duration treatment, and they don't like. I had today a patient, and he was anxious and talking about a lifelong treatment with the BTK inhibitors. So and some some are afraid of this, and we try to explain it's not lifelong. It's just that you take the BTK inhibitors when 2 criteria are fulfilled, it acts and it has no side effects. So you tolerate it well. So it's not lifelong. So, but I would say the majority of patients prefers non-chemo. I have the feeling because they associate chemo with the old historical approach, unspecific, and they love to have a non-chemo approach which promises to be targeted treatment. Yeah, so this is my impression, but I think Monique, you made it more in a systematic way, asking the patients with a certain score. Perhaps you can comment on this.
Well, Monique, do you want to give us the final word on what you know from an objective perspective that patients seem to prefer?
Yeah, so we did a study in the Netherlands about this, and in the ideal situation, patients would prefer a fixed duration oral treatment. So that's their answer from that study. And of course, we don't have it at the moment. So in that sense, it was clear that they want that. It's something that we cannot offer at the moment, but I think it's something that we can strive for in the future to find a solution like that. And after that, I must say, patients like the fixed duration a lot. We are a small country. Patients do not have to travel a lot in the Netherlands, so they a long time before they are in hospital. So after that, having not the ideal situation at the moment, they like the fixed duration a bit more than long life, a longer duration of oral treatment. And in my clinical practice, I must say I also see it like that. So there's a minority that prefers the longer oral treatment above the fixed duration.
So just to say thank you to all of you, I think that's exactly the point to close on, and to say that the future is in testing fixed duration oral therapies. And I think we have other lymphomas where we've seen that to be an effective strategy, and hopefully we'll see the same in Waldenstrom's macroglobulinemia. So just to say thank you to each of you for your contributions today, and thanks to those that listen to this online.